Is it visible?
Yes, sir.
Okay. So percutaneous dilatational tracheostomy is the process of creating opening in the anterior wall of the trachea. That is the definition of tracheostomy. This involves blunt dissection of pretracheal tissues, unlike your classical surgical open surgical approach, where you make a detailed dissection, identifying each and every anatomical structure. So this is a blunt dissection of pretracheal tissue followed by dilatation of trachea over a guide wire procedure using the Seldinger technique. The indications are when patients are having an inability to protect the airway, this they can aspiration, and when you want to do frequent pulmonary toileting, and when you plan to wean them off from a prolonged mechanical ventilation, this will reduce the anatomical dead space. So the patient, whatever tidal volume he is able to generate, will be able to sustain his oxygenation, and it will also minimize the sedation requirement. Instead of oral tube or nasal tube, which may be more irritating, tracheostomy is much more tolerated. So patient will require very little sedation to maintain the hold the tube in the airway. And the contraindications for this are absolute contraindications are patient or family refusal. You should not try this in an emergency. When the patient is in an acute airway obstruction, this is not the ideal technique. There you have to go for a cricothyroid puncture and ventilation rather than doing a percutaneous tracheostomy. So this is not the technique for emergency airway obstruction, and it should not be done in pediatric patient less than 16 years. And if a patient has a midline neck mass like a thyroid swelling, of course you can't do it that. And any uncorrected coagulopathy or platelet dysfunction is also, patient may have severe bleeding, and any infection at the site of doing this also is a contraindication. Relative contraindications are suspected or known difficult intubation, poor respiratory function, where even with a FiO2 of 60% and a PEEP of 10%, patient is not able to maintain the oxygen saturation. In patients who have a difficult airway anatomy like obese patients, short neck patients, or neck distortion, or post-burn scar contracture patients, in those patients it's very difficult to perform this. And patients who have tracheomalacia, they are also relative contraindication. And patients who have a C-spine injury or patient who have a C-spine immobilization with a cervical collar or rheumatoid arthritis. Now, insertion technique, she described: first assess the appropriate PDT, then consent, fasting, IV access, reoxygenate, emergency reintubation gear, and standard monitoring including ETCO2. Then there should be surgeon, anesthetist, and bronchoscopist available, all with adequate experience or supervision. You can do it under GA or LA or GA plus LA. And as you said, you have to pull back the ET tube towards the cords. And sometimes people use LMA also for ventilating to avoid damage to the ET tube cuff. And you have to practice a sterile technique. And finally, introduce the tracheostomy tube. There are different techniques. What is called Ciaglia technique, which is a graduated dilatation, Fritz vortex technique. Then there is a translaryngeal technique, and this is the classical method introduced first, what is called the Ciaglia technique, where you make a horizontal incision in the through the skin in the over this first and second tracheal rings, tracheal rings, or the third and fourth tracheal rings. Then you do a blunt dissection up to the tracheal ring, needle puncture through the first or second tracheal ring, and once you get a free aspiration of air, introduce the guide wire, and you do a graduated dilatation and use the tracheostomy tube for insertion. This is a very commonly used things, and the contraindications are things against this. It requires experienced operator, and you have loss of PEEP and tidal volume during this because you are going to introduce a dilator, remove it, and during that short time there will be loss of air. It may cause damage to vocal cord because you are pulling the ET tube up to the vocal cord, and it may take a few minutes to dilate. Spray of blood with inspiration if you have punctured any vessel, and sometimes damage to the posterior wall if it is introduced roughly and too deeply. And the second is the Krig's vortex technique. Once again, here guide wire is inserted with the use of guide wire dilating forces. So instead of needle and or cannula, you use the forceps to introduce the guide wire. Here the advantage is the less number of steps, faster dilatation, and again it requires experience and sterilization of forceps. Here also you will have loss of PEEP and carry volume, and again the same damage to vocal cords can happen because you are pulling the tube up, and more abrupt dilatation, so more damage, and again spray of blood can happen and damage to posterior wall also possible, and may want to insert a different tracheostomy tube, then it may be a wastage of the, if you can introduce the first bigger size, then you have to go for a smaller size. In that case, it will be a wastage. So this is shown here. This is not related to this picture, but this description. This is called the balloon dilatation tracheostomy. So I will describe it later. The third method is called translaryngeal approach, where ET tube is pulled back to gain access to the trachea. Curved cannula introduced into the lumen between the second and third tracheal rings. Guide wire is introduced and advanced in a retrograde fashion, not towards the carina but towards the pharynx. And a wire in the pharynx is grabbed with the Megill forceps, and patient is then intubated with a thin ET tube, and tracheal cannula is then attached to the wire and passed to the distal larynx. The tracheal cannula then pulled through the anterior tracheal wall and cut at a predetermined length and rotated 180 degrees by means of an operator. The thin ET tube removed and tracheostomy cuff inflated. I will show you the pictures to understand that. This is supposed to have low complication rate and safely used in patients with coagulopathy, and initial tracheal puncture is done under vision, avoids damage to posterior tracheal wall, allows to allow view throughout the procedure, and can be done as one-person technique. The contraindications are less well known outside Europe. More fiddly, needs experienced operator, requires sometimes view may be difficult, pulling tracheostomy through to damage vocal cords, only ability to insert incise tube, need to use different technique to change the tube. Of course, that translaryngeal technique is not very popular, none of us are practicing. And this is Sigalia single dilator method using Seldinger tube. That is the set that you see. And Prof percutaneous tracheostomy. This involves a single step screw type dilator, commercially available as Percutaneous kit. Dilator is rotated clockwise for lifting motion over guide wire. So these are the pictures of different. This is Krig's method, where after puncturing the tracheal ring, this is the forceps that is used to dilate instead of using a cannula and guide wire. So the forceps dilates the opening, and you introduce the first dilator, and then you use the tracheostomy tube. This is the retrograde method, what I told you, which is cumbersome. So you put the cannula and then introduce the guide wire towards the mouth, and then you attach the thin ET tube with the tracheostomy tube. Then once you come out, you pull out, and then finally the tracheostomy tube is here. You can see in this. Of course, I don't think it's a very suitable method. This is the Prof method, where there is a single step screw dilator. So here there is something like a check. You cannot advance it too much. and you use it by a screw method or rotation method to achieve and go into the lumen of the trachea. So Griggs method, Pantoni translaryngeal tracheostomy, Prof percute twist, these are all the things. Then what I showed you the picture earlier is the balloon dilatational tracheostomy. This is the second generation of Ciaglia technique. Inflation of a modified angioplasty balloon over a guide wire used to dilate the trachea. The tracheal stoma is made by inflating the balloon with a saline to 11 atmospheric pressure for 15 seconds. And this is an advantage over conventional single dilator percutaneous dilatational tracheostomy, where dilator needs to be removed before inserting the tracheostomy. So here there is no loss of PEEP or the ventilation. And there is a perception that balloon dilatation minimizes the pressure on the tracheal valve as compared to other techniques. So some of the procedural adjuncts that you can use for this are, so there are 5 methods: Ciaglia method, Griggs method, Provost method, and this balloon tracheostomy method, and what is the bronchoscopy can be used again for locating the insertion of the needle, whether it is correctly inserted and then whether the guide wire is correctly coming. And finally, after the insertion of the tube, you can assess the correct position of the tracheostomy tube. And some people use Bonfield symmetry scope for instead of the flexible scope to prevent the needle damage that can happen. Other adjunct that you can use is ultrasound. You can use to estimate the distance from skin to trachea, then accurate placement of introducer needle into the trachea, identification of aberrant vessels, enlarged thyroid isthmus to localize the rings and ensuring midline. And patients with anatomical abnormalities or those who are morbidly obese, this will be very useful. Of course, it is now become inexpensive. The ultrasound machines are available for 3 lakhs and 4 lakhs and readily available at the bedside modality. So, use of laryngeal mask airway during percutaneous tracheostomy is another modification. So, fear of inadvertent ET tube cuff puncture and accidental extubation have prompted the use of laryngeal mask airway, and it is its safety in critically ill patients with significant ventilator requirements is questionable. So, it can be used in more stable patients. And post-tracheostomy care ensure that the stoma wound is kept clean and dry all the time. The tube cuff pressure should be maintained between 20 and 25 millimeters of mercury. Cuff pressure more than 25 associated with risk of mucosal ischemia. Less than 15 leads to leak and risk of microaspiration. And the heat and moisture exchanger filter should be used for adequate humidification. Excessive suctioning to mucosal trauma will be occurring. So inadequate suctioning will increase the risk of tube blockage. So tracheal suction should be done gently and timely. Complications of percutaneous dilatational tracheostomy are bleeding, loss of airway, that is immediate, early, and late. You can classify them like, and hypoxia, pneumothorax, false tract, pneumomediastinum, posterior tracheal wall injury, esophageal injury, surgical emphysema, and early complications: tracheal ring fracture, tracheal tube obstruction, paratracheal placement, paratracheal wall injury, atelectasis, etc. Late complications: subglottic stenosis, unplanned decannulation, tracheal innominate artery bleed, displaced tracheal tube, delayed healing after decannulation, tracheoesophageal fistula, stromal infection, scarring, swallowing difficulty, and permanent voice change. So here are shown 2 types of this equipments used for that. One is called the white one is called the Vortex Ultra Percutaneous. Vortex Ultra Percutaneous. Short form is Ultra Perc. This is called the Ciaglia Blue Rhino. It is the earlier what I showed you as a balloon dilator is called the Blue Dolphin dilator. Whereas this more solid one is called the Blue Rhino dilator. So this is a picture of how you do that. First you check all the equipments, then infiltrate the first and second ring area with local anesthetic. And while doing that, you can aspirate and also make sure that you get a free air. And you leave a needle, introduce a needle there, introduce your guide wire, and then through the guide wire, you railroad the dilator and then keep on dilating, just like your central venal cannulation. What steps you do, the same method. And finally, put some stage sutures here on the sides to make sure that the tube is in stable position. Okay. So, percutational dilatation, these are the various steps that is being done. That is what is called this method. So we stop here and